Can fibroid cause infertility? Yes, it can cause infertility. And this is where I mentioned the location of the fibroid. If you have a fibroid growing inside the uterine cavity,
Yes.
then most definitely it's going to cause infertility. There's a lot of gaslighting, even with us who are in healthcare. Your period pain is not a problem, it's normal. If you're having pain, or if you're having a situation around your menses that is just not you, then that could possibly be endometriosis.
So even if I remove my uterus, I'll still suffer from endometriosis?
If you have adenomyosis and endometriosis, which almost they coexist, if you remove the uterus and you don't remove the endometriosis, you've not done anything. Endometriosis is just, well, let me be nice.
It's evil.
It's evil.
Are there any preventive measures to make sure it goes where it needs to go?
Unfortunately, we don't have preventive measures. For fibroid, there's really, it's more of genetic. There's no prevention for endometriosis.
Oh no.
There is no cure for endometriosis.
Hey guys, welcome to today's episode of LNS. My name is Lynn Ngugi, and as always, I'm happy that we get to meet for another thought-provoking conversation where we do the three things that we are doing this year. We get to learn and relearn. And I'm pretty sure today's topic is very relatable to a lot of people, even to men, because I know these are things that you witness the females in your life going through. We're talking about fibroids, we're talking about endometriosis, we are talking about PCOS, and so many other things. And I am so happy that we get to have someone who is very, very good at this field, and he will be taking us through what are these things and also what are the misconceptions around them. And also when someone says, you know, you're barren, you're infertile, is it really it? And what are some of the signs that we should never ignore in life? Especially women. He told me what he wants to achieve with today's conversation is one thing, tell you that period pain is not normal. I know a lot of us have been told, don't worry about it. When you give birth, you will stop feeling the pain, or when you take these kind of drinks, or when you take this medicine, you'll stop feeling the pain. But today, I want us to be able to demystify all the myths around these topics. I'm about to let him introduce himself. It's an honor to have him on the show. But before I do that, allow me to say thank you so much to our amazing partners of today's conversation, Kings Developers Limited. And I have said, if one of your goals is owning an apartment this year and you don't know where to look, why don't you take a look at Kings Developers Limited, an ISO real estate company that has great apartments for you. Not only do they have upper end, but they also have medium range and also affordable housing. Go to their place. You see that Prism Towers, the beautiful house hapo hapa hila. Iyo ni yao pia. Walk there, 5th floor, and tell them, Kings, what do you have for us? And also, to say thank you so much to you guys for watching. This is our road to 1.5 million subscribers. I do not take you for granted. You are the people who make me love independent journalism, because you've decided to be active contributors and participants of our work. So thank you so much. And the incredible team at LNN that gets to put this work together, I do not take you for granted. I've said you get to see me in front of the camera with my nice afro hair, but it takes a whole village to be able to put this work together. So shukran. And now, of course, without further ado, please allow me to let my guest introduce himself so that we can be able to learn and relearn. Daktari, karibu sana.
Thank you so much.
How are you?
Very well, thank you.
Good morning.
Good morning.
How is Kenya treating you?
Kenya is treating me just like any other Kenyan, I should say. Oh, that's a very interesting question to ask about this time. But yeah, pretty good.
Pretty good?
Pretty
I'm
good.
happy to hear it's
Thank
pretty
you.
good, Cynthia. But nice to have you.
Thank you for having
this
me.
early morning on our platform.
Yeah, they say the early bird catches the worm. So
yes,
I'm really glad
we
to
are
be
catching
here.
the worm.
Oh,
yeah.
most definitely.
Yes,
yeah.
we are about to get into a very educative conversation.
Yeah.
But before we go there, I know people have seen you obviously across your social media platforms. But maybe maybe someone who is bumping into you for the very first time, could you please introduce yourself and tell us what
Sure.
you do?
Thank you so much, Lynn. And my name is Dr.Njagi. I'm a consultant, obstetrician, gynecologist. I'm a laparoscopic surgeon, but my main interest is in endometriosis. God, I've been in practice for over 8 years now. And just as you mentioned, I think our main objective for today's show is to reassure women that painful period is not normal. And I think most part of this show will be busting some myths that have actually been believed for years.
I love your voice.
Well, let's put it, I have a little bit of a cold. Maybe that's the reason why.
I'm like, maybe Dr. can come and co-host the show 1 or 2 here on the platform. But let me ask you, sometimes even before we go into the topic, I love asking people their why. Why do you do what you do?
God, it's very hard for me to answer this question with one line. Over years, and I get this question asked to me a lot. If I'd look back the last 20 years and being where I am, I just feel that God predestined me to be here. My life has been quite mysterious, and when get to see the things that we are doing and the impact that we are making in reproductive health, honestly, I can only say that God predestined me to be doing what I'm doing today. So I think part of it is finding purpose in life, and you align it with God's purpose for you. 2006, it's a long story, but I remember in the middle of the night praying to God and telling God, I lived in the US before coming back home. And I remember praying to God and telling God, hey, please, whatever you want to use me, please use me. And take me whatever you want to take me on one condition, that wherever you take me, you got to lead me. So everything, I think even being here, this is what we were saying before the show, nothing by chance. I feel that, God had opened up the door for us to be here having this conversation.
I love that. I love that you found your purpose. I always say my prayer to so many people, because I get that question a lot also. Even on my DMs, you have people asking you, Lynn, how do I get to discover my purpose? What's my purpose? And I feel like it's a question we need a whole different show to be able to answer, but let's get into it. Period pain is not normal. That's a statement on its own. Endometriosis, fibroids, PCOS. Mimi kama kuna kitu najua, I am meeting so many people who have fibroids, and I'm looking at it. I've actually decided, is it a kawaida thing that a lot of people are meeting? They are either experiencing period pains, fibroids, endometriosis. Endometriosis not a lot, but fibroids, it's really starting to get to me. So could you walk us through, from a professional point of view, could you walk us through all these terms, right? What we get wrong so that we are able to unlearn, what signs are there, and also what preventive measures are we looking at?
Sure. Let's start by appreciating the woman reproductive system. So the woman reproductive system, basically being a gynecologist, our main specialization is reproductive system. So the reproductive system will consist of the uterus, the womb. And the function of the uterus is to carry a pregnancy. Basically, that's a function only. Then attached to the uterus will be the fallopian tubes. And the fallopian tubes usually act as a channel to communication between the ovaries, which now will be also attached to the uterus, outside the uterus. And this is where the eggs will be ovulated from. And then they will act as a channel between the sperms. So again, the uterus is connected to the female vagina or the birth canal. And this is where the sperms will swim into the uterine cavity, the fallopian tube. Eggs ovulated from the ovaries, then they meet at the fallopian tube, and then fertilization takes place. It's very important, because I know there are questions which will be coming in regards to infertility. Now, let's talk about fibroids and endometriosis, and I'm just trying to give a little bit of quick definition. Now, the fibroids basically means tumors. And when I talk about tumors, growth. So we have to be very clear. When we talk about tumor, we don't mean cancer. So tumor can be non-cancerous or they can be cancerous. Now, fibroids are tumors which are not cancerous. Now, how they develop from one muscle cell. So the uterus is made of mostly muscle cells which contract, and that's why a woman gets this cramping pain when they're having the menses, because the uterus is trying to contract to expel the inner lining which is shedding off.
Yes.
And of course, during birth, the uterus will contract, contracting to expel the baby. So that's really the function of the muscular component of the uterus. Now, for whatever reason, we don't know, these cells are regulated. By regulated, what it means, these cells can grow. Let's say a woman gets pregnant, so the uterus will get bigger in size to accommodate the pregnancy. So the body is able to regulate any single cell in your body. So say, okay, time for you to die, time for you to grow, time for you to regress, and so on and so forth. But for whatever reason, one cell is going to lose that control. And when it loses that control, it starts to grow and grow and grow and grow. That becomes a fibroid. So basically, fibroid is a tumor that, one cell has lost control. Now, 1, 2, 3, 4, 5, 6 to 100 can lose the control. And that's why you'll find sometimes you'll have a woman with 1 fibroid, you have a woman who has 2 fibroids, other you have 100 fibroids. Now, when we talk about the fibroids again, the symptoms for fibroids will depend on the location of the fibroid. Now, if you look at the uterus, it has different layers. You have the inner layer, which is the endometrium, which is the one that thickens and sheds off. And the thickening is to enable, should fertilization take place, the fertilizer will come and implantation will take place. Now, you have the middle layer, which we've said is the muscular layer. And then you have the outer one, which really, it's not any important in this situation. So if you have a fibroid closer to the lining of the uterus, those are very symptomatic uterine fibroids. So by symptomatic, what we mean, this woman will have heavy bleeding during her menses. She's, likely to have issues with getting pregnant. She might have some pain, depending on if much of it is inside the uterine cavity, and so on and so forth. The fibroid is from the inner lining, the lesser the symptoms we're going to have. So it's going to be less painful, less bleeding, and risk of issues with fertility is not as much. Now let's put in some statistics. Now that you've mentioned, you get to hear a lot about fibroid. If you look at, and I don't know why, I remember when we were in medical school and we were being asked what are the risk factors for some really tough conditions. We always say if you're of African origin is a risk factor. Now, we really find that women of Black women are more prone to fibroids than a counterpart Caucasian. Again, we don't know, research tells us. So I think it's our genetic.
What did we do?
I don't know exactly what we did. But then you'll find, if you take 100 women, about 70% statistic shows that might be suffering from uterine fibroids. Again, the only thing is that not all women will have symptomatic fibroids. So if fibroids are not causing any symptoms, we leave them, no problem. So sometimes I find patients who will go in for, let's say, an abdominal pain for whatever reason, which lasted about 3 days. They say, okay, fine, do an ultrasound scan. They do a scan, they find their fibroid. And they're, the problem is the fibroid, you need to have surgery. No, that fibroid has been there for possibly a few years. So this was what we call incidental finding. You found something else when you're looking for a different problem. So as long as fibroid are not really bothering a patient, then we don't do anything about it.
Naziki grows, they will grow and take charge. I'm looking at them as little aliens that are growing inside guys, we are having a reproductive conversation. I'm looking at them as aliens going inside my vagina. So will they not take control of everything? inside?
Really, again, if you
Or do
really,
they have a growth limit? Because if we are leaving them alone, does
Yeah.
it mean that there is a place the growth reaches, the limit? Now leave them alone; they can't grow past this.
Actually, apparently, they don't have limits. Sometimes I've had women who have come with like a really full abdomen full of fibroids. You actually think they are 9 months pregnant, but this is a woman who has had this for an extended period of pain, for extended period of time, and is either fear for surgery or fear for treatment, whatever that could be. And you really find that sometimes they're not symptomatic. They're not really causing any symptoms. So we say, it's really up to you. Some of the other things that, if they grow really big, these are some of the things that patient, will present with. Their bladder cannot really get full, so they keep urinating, so often because the bladder is not expanding as it should. You find that they lose weight because, again, if a woman has fibroids which are, taking the entire abdominal space, that means that the stomach cannot expand. So that means they eat little and then they get full
real quick.
Exactly. And you really talk to this patient and you say, this is going to improve your quality of life. It's really not a risk that is going to completely affect your life, but it's important. Sometimes you find these fibroids can grow really big and they compress on the ureters. So ureter is that tube that gets urine from the kidney to the bladder for the urine to be stored. So sometimes you might find that they are compressing on the ureter, leading to dilatation of the kidney.
Yeah.
So all these things, the bigger the size, some of these are some of the complications that would come.
Okay.
But the one that is really dangerous is bleeding. Sometimes we have a patient coming with a HB of 4.
With a what?
HB of 4, their blood level of 4, and normal should be above 12 and above. So this patient, they really need to have urgent care.
Okay.
Now, there's something that you mentioned I really would want to kind of demystify a little bit. The fibroids, remember, if you look at the anatomy, the uterus comes to the cervix and then into the vagina. So rarely do we get fibroids growing into the vagina. However, you can get a fibroid we call a pedunculated fibroid. So it grows from inside the uterine cavity and then it will start growing through the cervix. It comes out through the cervix and now gets into the vagina. And these I have seen. And they can really grow big in size. Now, this is the problem. This pedunculated fibroid, not only they're going to be uncomfortable feeling in the vagina, but because the blood supply is coming from where it's attached to the uterus, you really find there's no blood supply that gets to the end of the fibroid. So, the end of the fibroid start dying off. When it start dying off, then that dead tissue can get infected. So if getting infection, then really bad smell. With the bad smell, then the patient might start running some fever and and things like that. So these are all different kind of types of fibroids. Now, as I kind of conclude from the fibroids, I think the question that comes is infertility, inability to get pregnant, and fibroids. Can fibroid cause infertility? Yes, it can cause infertility. And this is where I mentioned the location of the fibroid. If you have a fibroid growing inside the uterine cavity, then most definitely is going to cause infertility. The reason is because either one, you really find that the space is occupied, there's no implantation that is going to take place. However, if we have a fibroid that is pushing on the wall of the uterus, it's big in size, what we get to see is recurrent pregnancy losses. Because the baby is growing and we have a fibroid. Now becomes a battle. Who will really take this space? And you find the fibroid, I've been here for a long time. I'm a tough human being. Let's he was going to lose the battle. And you really find that over time, because the uterus is not expanding as it should, you have recurrent pregnancy losses. But we should actually take this very, very cautiously, because sometimes I've seen patients who have fibroids, which I feel that would not cause fertility. Again, remember, because the fibroid is outside the uterus, but they have issues getting pregnant for whatever other reasons. It can be the tubes, which is the issue. It can be the eggs. It could be the age. There are many factors that contributes to infertility. So once you have this scan done and they find there's a fibroid outside, they, oh no, the reason why you're not getting pregnant is because of this fibroid which is growing out, which we know actually that would really not cause fertility. So it's very important for patients who have issues with fertility to make sure that they are having review by someone who is keen in fertility, someone who really understands, some of these causes for infertility, because sometimes they might need to have a full workup. So fertility and fibroids, yes, they can be, but really not as much.
Let's go back to the cell that left wherever it was going and comes and causes this. Are there any preventive measures to make sure it goes where it needs to go?
Unfortunately, we don't have preventive measures. And some of these conditions, we really, it's like now where we are getting vaccination for almost everything.
Yes.
We're just trying to prevent conditions. Unfortunately for fibroid, it's more of genetic that has gone bad, or this control has really gone bad. It's a genetic level. Really can't really do much about it. It's sometimes it's our genetic code, how our nose gets to look like. We might not really have much control over it. Just our skin color. We cannot really change much about that. What we say is, regular check. If you have some of these symptoms, just make sure you're seeing somebody who really can sort it out. Early diagnosis, I feel, is the most important thing in most of these conditions that we really get to discuss in reproductive health.
Okay. And can the tumor break? And I'm going to ask this question.
Yeah, please do.
I know Doc is looking at me
no.
Man, Lynn.
That's why we're here.
But can the tumor break? And if it breaks, can that be discharge? And what color is a fibroid tumor?
Wow, God, no, it can't be. Because remember that this tumor is attached to the uterus. And it feeds from the uterus, through the blood vessels and so on. So it's very unlikely for these fibroid, especially if you have one that is overgrowth of inside lining, the one that we are calling a pedunculated fibroid. It's very difficult for it to break on its own. And if it's growing on the uterine, which most of the fibers, more than 18% of the fibers, are actually going to be harbored on the wall of so it's growing on the wall and then just keep growing, still on the wall of the uterus. They will never pop out. They can go through some changes. This is a little bit advanced for our conversation today, which we call degenerative changes. So with the degenerative changes, that's when you find the one change that will happen is during pregnancy. And during pregnancy, what these changes will lead to is pain during pregnancy. So we find women who have fibroids, they get pregnant, those who get pregnant and they happen to not lose a pregnancy, they can have pain during the pregnancy. And all that we do, we just manage their pain. We just give them, some painkillers and monitor them through their pregnancy process. But to answer your question, now they do.
All right. Okay. I'm understanding. I don't like I don't like it. I don't like that cell that decided to leave its master. But I love that you've broken it down in a way that I've also been able to understand. And I love that you've also made that correlation between someone who is pregnant and they still have fibroids at the same time. Would you recommend, if my fibroid is really too crazy and I'm pregnant, can I get surgery?
You mean surgery to remove the fibroid?
Yes.
No. So let's give an instance. A patient came to me, they had a fibroid, we were planning for surgery. Right before surgery, she tells me that, hey, Dr. Njagi, I'm pregnant. At that point, the fibroid is no longer a priority. The life the pregnancy becomes a priority. And we'll have to walk with the patient through their journey. Depending on their presentation, God forbid they lose a pregnancy. Now, we now have to address that issue. But as long as she's pregnant, we'll have to journey with them through their pregnancy journey. Sometimes the question, patients come and say, oh, I was told that when I'm delivering my child, I can deliver through cesarean section and then they'll remove the fibroid. Bad idea. Why is that? Is because the uterus has grown and, so huge, and it's so much blood supply that is now coming to the uterus, because this blood supply then goes to the placenta to feed on the baby. So the uterus is very vascular. And if it's that vascular, you don't want to go out there and start messing up. Your main objective is get in there, get the baby out, close, worry about it later. The reason is because you see fibroids will also grow in size during pregnancy. So wait for the uterus to go back to its normal size. The fibroid is also going to shrink. There's going to be less blood supply. Then work on it.
Okay.
However, the doctor might find that the fibroid, it's on the way where we usually make the incision or we make the cut to get the baby out. We find the fibroid is on, along that, our way. So in that situation, you really don't have an option. You'll have to, make an incision, get the baby out, and at the same time, the fibroid. But fibroid should not be removed during cesarean section.
Okay. How is sex though if I have fibroids?
No, it's no problem. Unless, it's like, there are those big ones like you're pregnant. It might be, a little bit tricky, but ideally it shouldn't be a problem at all.
So if I'm...
Because the sexual life, remember, and I think this is the reason I was actually talking about the fibroids, popping into the vagina. Remember, we've actually think about the sexual intercourse.
Yes.
The main organs that are responsible for this, process will actually be the birth canal. And if there's nothing inside the birth canal, it should not be a problem at all.
But Kwani, how big is my reproductive system? Because, the size also. God, I'm going to try it. Lynn,
this is a reproductive
don't go there.
health.
It is.
It's a reproductive health. Yeah,
so
please,
there are people with very big pens.
Yes.
So if it's big, says 10 inches.
Yeah.
If
10
it
inches, yeah.
Doc, I swear I'm going somewhere.
I'm still learning a few things here.
Ndio nasema, see, the more it goes in, the more it pushes.
Now, again, the uterus is actually held in place by certain ligament. So by the virtue we are saying that the uterus has fibroid, has got nothing to, that affect the descent of the uterus. Now remember, the cervix is the one that you find in the vagina. Yeah. So what actually we find, with the bigger the uterus, it tends to pull the uterus up. Exactly. Okay. And that has literally nothing to do with the change of position of the cervix inside the vagina. So usually that will not really change under our circumstances. Unless, what I mentioned, you have a fibroid that is actually popping through the cervix into the vagina. Unless there's really a foreign body inside the vagina, there should never be a problem with sexual intercourse. There are some conditions where it's not really common here, but we have something we call uterine prolapse. Yes. A uterine prolapse is after a woman gives birth to many children, the ligament usually weakens, what holds the uterus into place, and sometimes you might find the vagina, the uterus is actually descending. So you find the vagina usually about 9 centimeters long.
Yes.
You can find that sometimes the uterus can fall all the way to the opening of the vagina. Still, again, in those situations, having sexual intercourse is really not a problem, because what a woman has to do is actually just, just push it back in, have sexual intercourse, and really that's usually not a problem.
Who is pushing in?
Well, they get to decide, this is a team, so.
Oh, no, I thought like someone individually can decide.
You can actually, yeah.
You can.
During sexual intercourse, but you see, off that period, then, the uterus will still.
They will still, okay.
So this is what, conditions we call uterine prolapses or prolapses, things like that.
Okay, I appreciate it. Honestly, najua tumeelewa sisi wote.
Yeah.
We close on fibroids?
I think so. Was there anything that I think I have not talked about fibroids? Really, no. I think mine is just to reassure our viewers that don't freak out when you're told you have a fibroid. I had a woman called me yesterday and tell me, "Oh, it's very urgent. I really need to see you." I'm like, "What's the problem?" "No, please don't. Please make an emergency appointment. I've been told I have fibroids." "Are you bleeding?" "No, I'm not bleeding, but I'm scared the hell out of my fibroids." "No, don't worry about it. They have been there for years." Just because you met somebody today, did a scan and told you have fibroids, it doesn't mean that it now becomes an emergency. However, if the patient is bleeding, heavy bleeding during their menses to a point whereby they start feeling dizzy, they start feeling breathless when they are walking upstairs, low energy, oh no, that means that their blood level is getting low, and that needs to be sorted out.
Okay, beautiful. Guys, I hope we are learning together. Endometriosis, let's go there.
My goodness.
Yeah, that's a hard one.
Endometriosis. It just gives me goosebumps, Lynn. I feel that apart from cancers, the most notorious condition, poorly understood, I would say. It's terrible. Yesterday, I had a patient we operated with our team at Third Park Hospital. And this was, we were how many? God, we were 4, including a cardiothoracic surgeon. So there's a young lady, she's 30-something years old. I got to know her mid last year. And every time she's in her menses, she gets this chest pain and she develops fluid on the right chest. And she gets drained. This fluid gets drained because what that means, the lung don't get to expand as they should, because now outside this chest cavity, this fluid that is filling up. So the lung can collapse because of this fluid filling up. They cannot breathe normally, they cannot function normally. So she's had this fluid tapped for a number of times, and that we remember a story of late Jambi Koikai, something like that. And when I was told this happens during her menses, she was referred to us, and we just learned that she had endometriosis of the chest, and that's terrible. I mean, terrible. So we operated on her yesterday, and we found out that she had endometriosis of the chest, and also the right side has 3 lobes, the lung. So the lower lobe of the lung was not expanding as it should, and we just came to learn that he also had endometriosis. We put a camera in the abdomen. We found she also had extensive endometriosis. The uterus was completely buried, and future of fertility, it's uncertain, and that's endometriosis. It's a notorious disease, terrible. Unfortunately, we don't talk about it, and I'm really glad that we are talking about endometriosis. What a better way to start the month of March. We usually say month is Endometriosis Awareness Month, where we got to talk about it, and I really appreciate getting this platform and creating awareness. And I know you have millions of viewers who will find this important. Now, that's why endometriosis, I think, is very, very deep. Now, let me be a little bit personal, and then I'll take endometriosis.
Okay.
Last year, one of my niece calls me and she tells me, "Uncle, life is just difficult." I'm like, "What's going on?" She lives in the US. She tells me I'm having really bad pain during my periods. And me being an endometriosis specialist, it just knocked me off. So the story goes, she's seen a few gynecologists up, and she's been started on treatment. It's not working. And it was so bad. She was not able to function. School was a problem. But what made my heart sink? Her mental health got messed up. And I remember talking to her. I put her on some medication. I remember sending some medication because some of the medication we locally use here, they're not available in the US. And she wouldn't get better. And she would call me really messed up. So I said, okay, fine. December, you guys are coming home. Please come home. And no question, I'm going to operate on you. Okay, now there's a little bit of controversy here, and I know our viewers will be going, but we thought doctors did not operate on family members. Well, you really have to define what is really family member that you cannot operate on, and who is better placed to operate on. So I remember talking to my sister, and I said, I don't care. Now I'm taking over. I'm the parent here. She needs surgery. So she came in, and January 6th, I operated on my niece. And I found out that she had endometriosis. And man, it was terrible. Lynn, it was terrible. That this condition that you've worked for many years now has no boundaries, actually knocking door in your own home. We thank God she went back, she sent me a message, telling me, "Uncle," this is what she said, "Thank you, because you're the only one," mark the words, "who validated my pain." That was huge. So basically, what does that mean? Is that there's a lot of gaslighting, even with us who are in healthcare. Your period pain is not a problem, it's normal. The one that pisses the hell out of me, it's coming from us, health professional, where they tell the patient, like, go get pregnant and the pain is going to go away. Now, going back to the patient we operated yesterday, she's not going to get pregnant because the uterus is completely taken up by endometriosis. The fallopian tube, the one we were talking about earlier, is completely taken up by endometriosis. Leave alone getting pregnant. She cannot have a partner who is going to be able to live with her with this excruciating pain. Endometriosis is just, well, let me be nice.
It's evil.
It's evil. It's evil. And I think for me, being a gynecologist, I'm a feminist. Women should get nothing but the best. Really. All right, let's talk about endometriosis.
Yeah. I'm glad your niece is okay.
She's fine.
I'm glad you were able to, the way she said, validate.
We needed to validate. And I could not find anybody better place to operate on her than,
you
know.
did the right thing.
Yeah, sometimes we do some crazy things hopefully for the right reason.
Yes.
All right, let's talk about endometriosis. Again, I go back to the uterus. Remember, we say we have different layers of the uterus. We have the inner layer, which is what we call the endometrium. Thickens, sheds off every month. A woman gets menses. Thickens again, sheds off. If we have any evidence of similar tissue to the endometrium growing outside the uterus, that is a diagnosis of endometriosis. So I'll repeat it. Tissue similar to the one that lines inside the uterus growing outside the uterus. That's endometriosis. So for this patient who had it in the lung, we could actually prove that these tissues which are now invading the lungs and the lining of the uterus are actually similar. They have some similarities to the one that lines inside the uterus. So what happens? When a woman is menstruating, this tissue also tends to also bleed. And with this bleeding, there's what we call the inflammation or the reaction. And with this inflammation, now comes the symptom. Crazy pain. And that's why we started by saying, painful periods, I don't care where it is. As long as you're finding pain here during your menses, or in your eyes during your menses, whatever, then that's not normal. Now, going back again, because sometimes I talk about endometriosis and the pain, and this is the question I get asked. Cramping. Now, the cramping the woman gets, it's just what we were talking a little bit earlier. The contraction, trying to expel this lining that is shedding off, just coming out. And also to contract the blood vessels to reduce a little bit of bleeding when a woman is on her menses. And this is just a discomfort. I kind of don't know how it feels like, but
It's bad.
The cramping shouldn't be bad.
But you feel there's a change.
Usually there is.
There's a discomfort.
Discomfort is the word to use. But if now this discomfort graduates to a point whereby you can go to work, you need to use painkillers, during that period you're just not you, during that period you're
Sitting on a cold floor.
Sitting on a cold floor.
Or putting some hot water.
The hot water bottle. No, that's not normal under all circumstances. No, absolutely not.
Even rolling on the floor.
Oh, come on now.
Eating bananas.
Oh, come on now. No, it's not. As long as it affects your quality of life, it's not normal. And this pain can be dated as early as 1500s. Now, there's actually a diagnosis we used to give young girls, high school, when I was a medical intern, when they'll be brought to the hospital in the emergency with severe pain. This is actually a diagnosis we used to give them, which was called hysteria. Wow, there's no discriminatory diagnosis like hysteria. Why so? It's because hysteria was thought it's a condition that is originating from the uterus. Hyst is originating from uterus. So when we say someone has hysteria, men never suffered from hysteria. Only women who suffered from hysteria, because they actually thought that their condition is coming from the uterus, and so many discriminating things that went around menstrual period. There are places where women could not go to the bar during their periods. We know some places where you cannot go and pray during your menstrual. I mean, come on. I mean, why? So if you're having pain, or if you're having a situation around your menses that is just not you, then that could possibly be endometriosis.
Oh boy.
Now, let's bring some statistic back home. As much as you said you don't get to hear a lot about endometriosis, then I'll ask, how many times you and your girlfriends will be there sitting and talking about your periods?
I'm the girlfriend.
You?
I'll be like, oh my God. Actually, you sit and then you're like, you're like, it's like a train passing by. So you're just like, guys, isha. Then you must get like, oh my God. Then you feel like, oh my God. Like you can actually cry. Like you want to cry. Because it's like, you've not experienced.
Wow,
do you know?
God, no, I.
Of course, let me show you how it feels. Can I use your arm?
Yeah.
So it feels like.
Oh, crazy!
Then.
Yeah.
then shh, then another one that will even give you shocks.
What I usually tell men, if you really want to have an experience of these pains we are talking about, is for the women, and you want your man to experience, please, I'm not advocating for violence, please, disclaimer. If you can hold their, what do you call them? What do you all call them?
Their balls?
Okay, wow, yeah, that one, okay. I'm a gynecologist. How would I know?
They know we have it.
Okay, all right.
Class in
it's
session.
It's a reproductive health session here, you know. And you just kind of squeeze it a little bit. Please, but don't do this at home.
No, but I feel like they should.
Okay.
Because I know there are men who would love to understand.
Exactly. Just kind of understand what we are talking about. And just the thought of it, I can see the man in the house. Just the thought of it, they're just clenching and
Guys, like, no.
This is what these women go through.
Yeah,
and it should not happen.
Yes.
That's
now you feel
bad.
it. Now that's the pain.
It's really bad. So bringing against statistics, we like talking about statistics. We don't have local statistics like in Africa, but this is what we know. 1 out of 10 women suffer from endometriosis. No, that's huge. So for every 10 women, 1 will suffer from endometriosis. Now, we don't know about African statistics.
Why don't we have African statistics?
Because we're just lazy. We don't like to do research.
You're telling me.
Okay, not me, but yeah.
No, not you. You're telling me in Africa, we don't have statistics on endometriosis.
We don't have statistics of endometriosis. It's embarrassing for me talking about it because I think we are the champions of endometriosis. But this is the reason, again, just to, cover us a little bit. This is something that has not been talked about. There are a lot of myths surrounding menstrual health. How do you get to talk about your period? Young girls cannot talk about periods with their parents. If you're having periods and pain, the myth is like, no, it's okay, it's going to be fine. You need to be a woman. Crap. You're told, oh, no, it's okay. Once you grow up, you get pregnant, the pain is going to go away. So what tends to happen is these young girls tend to endure the pain. And this is what I get patients telling me in my clinic. I've always thought about this pain is normal. How do you normalize pain, y'all? How do you normalize, like every month, you have to get a job. Oh. Yesterday, I had a patient who she told me, I have been pricked every single vein that you can imagine. She has a contracture, because they have pricked here, she got a wound, and when it healed, I'm not kidding, Lynn. And when it healed, then it healed with scar it tormented me. It really did.
You have to take Brufens. That I know.
Brufen doesn't work. It gets to a point it doesn't work. The patient, my niece was taking double dose of Brufen. Now, can you imagine double dose of Brufen? What is actually doing to your liver? What is actually doing to your kidneys?
Well, what does it do?
No, just really going to affect your liver, because the liver is the one that detoxifies these drugs and so on. So the more you're actually taking these drugs, the more it's actually going to affect some of your organs. Now you get to a point whereby the pain, because you're really not addressing the issue. So the disease keeps getting worse and worse. Painkillers don't work. You add another painkiller, you get injections. Come on, it's terrible. Again, infertility becomes an issue. We know this is against statistics. We borrow from Western statistics. The state that 45 to 50% with infertility could actually be suffering from endometriosis. So if you take 100 women who are suffering from infertility, actually maybe about 40%, 45% could be suffering from endometriosis. And this is true because some of the women who come to see us, not because of the pain, say, oh, me, I learned to normalize the pain. The pain is now no longer a problem. I know that during my menses, it's going to be hell, but thank God I have 20 days that are going to be slightly okay. But all that I need is a child. Now it's the community, is my in-law, it's everybody. It's my partner has gone and has impregnated somebody out there because I'm taking too long. Please take care of my mental status. We do check their fallopian tubes. We find fallopian tubes are blocked. We go in and we find, kumba, the reason why the fallopian tubes are blocked is because of this damn endometriosis. Yet we don't talk about endometriosis.
Yeah.
Yet we were not trained. I was never trained about endometriosis when I was training as a gynecologist. So
are they training now? The upcoming ones?
Well, I believe they are, yeah, and I believe they are.
Yeah, because now.
Yeah, but we have to make noise, Lee.
Yeah.
We just have to make noise. We have to talk about it.
So, well, fibroids, they are the tumors. Endometriosis is
a growth.
So, the symptoms, obviously. Period pain.
I say
heavy bleeding.
And let me bring in something else to endometriosis. There's another condition that is in the family of endometriosis called adenomyosis. Now, remember we said when we have tissue similar to the lining of the uterus growing outside the uterus is endometriosis. It can grow to the ovaries, it can spread everywhere, it can go to the lungs, it can go to the intestine, it can go to the bladder, name it. When you have this tissue similar to the lining of the uterus now infiltrating the muscular wall of the uterus, that is called adenomyosis. Now, adenomyosis is very notorious. Why am I saying it's notorious? The reason is because the treatment, which will come to it, of endometriosis is cutting out this growth, as we are calling them. So, if it's growing on the lining of the pelvic wall, we just put in a camera laparoscopy, we go in and then we cut it out. But now you can imagine if it's infiltrating on the wall of the uterus. What are you going to cut? What are you going to leave behind? Really nothing. Now, these are the patients who are going to present with excruciating pain, heavy bleeding, infertility. They can have back pain. They will have pregnancy losses because the more it grows, we can have focal adenomyosis. That means it's concentrated somewhere. We can have diffuse adenomyosis. That means it's actually, almost the entire uterus. Now, these are very difficult because you really don't have way of really cutting the hair because it's like it's infiltrating the wall. And the cure for adenomyosis, not endometriosis. Yes. Very specific, not adeno. The cure for adenomyosis eventually is a hysterectomy, removal of the uterus. The cure, eventually. But now you can imagine, you cannot give a patient this option if they're still planning to get pregnant.
Mm-hmm. So even if I remove my uterus, I'll still suffer from endometriosis?
Now, you're asking a very, 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 very good question. If you have adenomyosis and endometriosis, which almost they coexist, if you remove the uterus and you don't remove the endometriosis, you've not done anything. This patient will still suffer from endometriosis. So, the aim should be to excise, remove endometriosis. Now, I have seen all kind of crazy treatment there that makes me feel really unhappy. Not only do some women get an option of having the uterus removed as a treatment for endometriosis, which is baloney. Some would actually get their ovaries removed, and that is wrong. For lack of a better way, how now? Well, this is really the argument.
Yes.
Let me
Take us there.
Let me take you there. We know that endometriosis is an estrogen-dependent condition. Estrogen is produced by the ovaries. So, some clinician would actually, some of my colleagues, or some of us physicians, would actually think that by removal of the the ovary, you reduce the production of estrogen that might make the situation better. No, it doesn't. It really doesn't. What you've actually done, some actually remove both ovaries. What actually you've done, you have castrated that woman. It's actually called castration. And we know castration was punishment that was given men back in the days where their testicles were removed. So our testes is synonymous to women because that's what produces testosterone, women's ovary. So you've actually castrated. So what have you done? You've actually predisposed them to dry vagina. You've predisposed them to early menopause. You predisposed them to issues with their bone density and so on. That doesn't help. The goal should be aimed towards removal of the endometriotic lesion. And that's what we should be aiming out for. That's the gold standard for endometriosis. Now, I'm not saying there are no rules for medical treatment, but we know, and I say this categorically, we have actually found it, that when you give medical treatment, which can be combined contraceptives, some hormonal treatments, painkiller really doesn't work. Let's not even go there. You're just numbing the pain by doing absolutely nothing to the root cause of the problem. We know that these hormonal treatment, they just suppress the endometriosis, if at all they do. But when somebody has so much disease, good luck giving them a whole gallon of this hormonal treatment. It really doesn't work. So it just kind of helps in suppression. The symptoms might get better, but for the vast of the patient, symptoms don't get better. So some will say, I've been on Dynogest, some will say, I've been on contraceptives, some will say, I've been on injection whereby my menses have been stopped, some medication we call GnRH. I'm being very careful not to mention the real names here, but GnRH, which really cuts off the menses, aiming to suppress. We know these medications really are not going to work. You need to go in there and cut out the disease. And once you cut, surgery is the gold standard anytime. No question about it. And once you do that, now you can suppress. And what you're suppressing is to reduce the risk of recurrence. I hope that kind of makes sense. And this is what I usually tell. When we were working in the village, you remember back in them days, and you have so much weed. Yes. And there was, you remember Gramaxon?
What now?
Gramaxon. Ilikuwa dawa ya
kunyunyuzia.
Na wewe ilikuwa.
Hey doc, I know the dawa. That's the name. Yeah. Maybe not the name.
So basically, what do? Do you go and spray when you have so much weed, or do you go weed and remove the bulk of the big weeds? And since you know there's going to be the seedlings, which you're going to, and then when the seedlings start coming up, then you choma them. Basically, that makes sense to even to a layperson. So, and that's what we say. The suppression should be after you have excised the disease. Yes. Then after that, because we know there's recurrent. Again, we don't know how endometriosis develop. We call it as a disease of theory. Some feel it's retrograde menstruation. Some have found, remember we started from a single cell, all of us, and then
200.
Exactly. And then we find that there was what we call differentiation of cells, like, this cell differentiated to become the eye and so on. So we find some theories state that when this differentiation was happening, some of the tissue similar to this were left somewhere behind, and that's how, it's not very clear. That make it very difficult for us to prevent endometriosis. So we do not have, number one, there's no prevention for endometriosis.
Oh, no.
There is no cure for endometriosis. That's pretty sad. So what is our responsibility, Lynn? We got to talk about it. We got to educate as many as possible. I wish the lady we operated yesterday, we caught her 10 years ago. We would have given her hope. Getting pregnant would have given her hope, possibly not to develop pulmonary or lung endometriosis.
And I think people will also think endometriosis is for down there. They wouldn't think lung, here. It's evil.
Yeah,
it's weird. For the women who are on contraceptives, what's the effect of that if you have fibroids or endometriosis? Can the contraceptives make it worse? Family planning.
Contraceptives, okay, let me take a sip.
Okay. Let me help you.
We should, yeah. Well, contraceptive is, let me be very honest, a very controversial subject.
Yes.
Again, a lot of myths that goes around contraceptives and the different beliefs. But from a medical perspective, we know that contraceptive, their aim is to prevent pregnancy from taking place. And most of these contraceptives are hormonal based, which some are made from progesterone and all combination of progesterone and estrogen. Again, these are hormones that are produced by the ovaries. So when we give the contraceptive as treatment, the way we do this, we are tricking the body to think it's pregnant. It's in a pregnant state. Why I say this is because pregnancy, it's a high progesterone state or period.
Yes.
So when we give you progesterone, we are kind of tricking your body it's pregnant in a way. So some of these hormones will either not produce just, and that's how we get the effect of these contraceptives. Now, you've asked, what are the effects? The treatment, when we give contraceptives for treatment of endometriosis, the regimen or how we give it is different from if we are giving the combined contraceptives for the purposes of contraception. And this is where, sometimes we kind of miss it out. So what we really want to do, we just want to give a continuous therapy if we are treating for endometriosis. So what we are doing, no menses. We are basically cutting off the menses because we want to reduce the activation of this tissue because they're activated by the hormone. So they're activated, so they become active, and then they become active, then they become active, they become active, they become active, they become active. So they keep spreading and growing. So we just want to hold menses and just kind of hold it there. Yeah. And this is whereby, even for young girls, as early as 17, 18, when they start having this presentation, we put them on contraceptive. We just trying to cut off their menses. That is the aim, basically, for this hormone. So we can put them in a pseudo or not pseudo pregnancy or like a pregnancy state, or we can put this patient on menopause state temporarily. And this is where you get injection, the medication I was talking, GnRH agonists, you get injections and it really stops your mess. Basically, that's what we are aiming for the treatment of endometriosis. Now, what about fibroids? Again, we know fibroids are estrogen dependent tumors. So we know that they are going to grow during the reproductive period. So any treatment that we are going to subject a woman to, which has estrogen, we can actually make an assumption that is going to affect the growth of the fibroids.
Wow.
So it's again, there's really a lot around these contraceptives and these medications. They are totally believe that, patients should not be on this treatment. There's a lot of which it should be like a full
show on its own.
show on its own.
I hear you. So sex, again, intimacy.
Yes.
When you have endometriosis, it's going to be painful.
Yes. Yes. Again, that's another symptom. Painful period, painful sexual intercourse. Especially, and we usually ask, especially on deep penetration. The reason is, remember, you have these tissues growing. They start to grow behind the uterus, and remember, way down at the uterus, that's where the cervix and the vagina comes in. So on deep penetration, when you push, when the male pushes up the cervix, there's that stretching. And with that stretching, and you already have this inflammation going on, or sometimes you have the endometriotic nodule, and then you're tipping on that nodule, it's going to be painful. Painful. So it's usually typical if there's deep penetration pain. So if you have pain during period, deep penetration, some will come with pain passing stool, because you can also have this endometriosis now infiltrating the rectum. So you'll find now patients will present with bloating. Some will present with constipation. In severe cases of bowel, they can actually be bleeding from the anus, and they'll go for a colonoscopy. Colonoscopy is, oh, there's nothing, everything is normal. And then they get really frustrated. So you find women are just generally fatigued during this time. But the one that I'm seeing so common is mental health. So you can imagine, Lynn, since you started your periods, you've known nothing but pain. No one understands. People say you're malingering. People say you're just seeking attention. In school, teachers will say, for high school girls, they'll say, hey, mtoto wako hataki kusoma, anajifanya, kwani ni yeye peke yake special, na hii ni shule ya wasichana. I mean, come on.
At work, they'll think you didn't report because...
Now, this is to the bosses. Now, I'm talking to the bosses. Kindly, if you have a woman who comes to you and they tell you during their menstrual period they're in pain, please just understand that.
Thank you.
Please, for the bosses, please just understand that. Please just.
I can't wait for our 3 days of no work in Kenya. As a rule.
Nice.
Hey, doc, advocate for it. Hey, advocate for it. Hey, the way things are, please. I know there's a reason other countries are doing it. Because then they have gone and they've researched. And they have the statistics. And they know numbers don't lie. Numbers don't lie. But so let me talk about food. I want to briefly touch on PCOS or PCOS. But let me talk about food. Some people might think there are certain foods that, what's the correlation between fibroids, endometriosis and food? And also, utapewa kitu ukunywe itasaidia. Are there foods that can help the situation?
No.
Or is there?
I'm sorry. Kuna hapo unapatiwa concoctions. We are in an era of concoctions. Maybe this is a concussion.
No,
we are an era of concussion. But not really an era of concussion. Let me see, I think it's an era of frustration. Why is patient frustrated? Patients are frustrated because our healthcare is, what it is actually. You go to the hospital, there are now medications, you're going, sometimes we are not available. Come back next week. I mean, again, we are not validating your symptoms. So what do you have? You're going to go to some guy who promises you heaven with some concoction which is made out of God knows what it is made out of. And then it knocks you off for some time and you say, oh God, hallelujah. So we actually are frustrated,
Lots.
society, like really frustrated. But let me not completely dismiss our food stuff and all that. Of course, we're still doing research. There's still a lot that we really need to understand. For fibroids, really nothing much, because we know these are purely hormonal dependent tumors. But we know for endometriosis, the pain is from inflammation. So we actually finding our research suggesting that if you eat food which are less inflammatory, your symptoms could get better.
Yeah.
And I mean, we know would be red meat and processed food, packaged food. I think we're going back to how our ancestral parents, where they ate right from the garden. So it's actually coming from the garden. But now we know that, it's coming from the garden, but you don't know what is being subjected to. It's terrible. I was talking to my dad, and he was telling me he does not recall any time, planting maize, and now maize had these doodles that they used to spray. I mean, I remember when I was younger, that I'm old, but things have changed. You now process. It's processed. It's fast food. Now we are fast life. Everything is fast. Come on. What are these things doing to our bodies? I mean, you look at it. It's everything. Obesity, cardiovascular issues. Name it. Why are you looking too far? We are what we really eat. So this food that are going to increase, on inflammation, and they are going to worsen some of these situations. So I would say, it's very important we actually check on what our diets really are.
Yes, sir.
Yeah, and toxins like pollution, tobacco, and alcohol consumption. All this, we found them having effects on health and the inflammation. And there's another theory for endometriosis that touches on body immunity. That when our immunity is also suppressed, then we find some conditions really getting aggravated.
PCOS. What's that?
PCOS. PCOS is polycystic ovarian syndrome. And it's another condition that we commonly see. It's a condition that has been, in a way, been mistaken for these other condition, endometriosis. Well, as we know, they can exist. Basically, this is what happens. The process. You start your menses today. Once you start your menses today, there's going to be certain hormones called follicle-stimulating hormones. Follicle-stimulating hormone, it is actually a hormone as it is. It's a hormone that is stimulating a follicle. What is a follicle? A follicle is an immature egg. Okay, so go back a little bit, Njagi, make it a little bit clear. When you, Lynn, was born, you're born with a certain number of eggs, okay, which during your life in your mama's womb, or when you're developing, or these were developed, some. So every month, there's going to be a recruitment of one or whatever eggs to start to develop. Some are going to complete, some are going to not complete. And when this happens, so it's keep growing bigger in size to a place where now it's a mature follicle, ready to be ovulated. On day 14, they are about, a few hours thereabout, there's going to be another hormone that is going to be produced that is going to help this ovary, where the egg is, just to pop and open egg to come out. And then the fallopian tube to pick up the egg.
Yes. Straight.
to the fallopian tube. Then, around that period,
Hey, doc. Yes.
Around that period, then we might find the counter partner swimming,
Coming.
and swimming.
Come my way.
Yeah. And out of like 100 million,
Yes.
this is a mysterious story
I
now.
know, man.
Out of 100 million, only
one.
Only one. So we men, as much as I was talking about being squeezed, 4 million and only one, Yeah. We are story, all of us. We are story of one successful swimmer.
Yes.
All right, okay, right.
The one that succeeded.
That one succeeded. One out of 400.
Yes,
oh
man.
my goodness. Wow. So you can imagine if all were successful.
Who's Tammy? Who's Tammy?
So then after that is, happily ever after.
Yes.
Sometimes the twins comes in and so on. And there was Lynn, there was Njagi, there was all of us who were here. Now, for some reason, this process of ovulation does not get completed. For whatever reason. Again, we really don't know. This is something strange about our condition. So what you'll find that this egg never ovulated. And now let me mention something. When they're developing, there's also fluid produced inside here. So you find there's like a fluid. So again, that process, another one, process, another one, process. So you really find that ovulation is not taking place or completion of this process we call it in medical term folliculogenesis. Wow. So it does not get completed. So now what you're going to happen now, one, you're going to find that woman does not get their menstrual period. Because you ovulate, you menstruate. You ovulate, you menstruate. So the fact that you're not menstruating, it means that you did not ovulate. So basically when a woman gets postmenopausal, it's not that they have stopped menstruating. They have actually stopped ovulating. They have utilized all their eggs. So one of the symptoms is a woman will go for 6 months, 3 months without menstruating. That basically means they have not ovulated. That's what it basically means. So you'll have now, when we do a scan, when we're doing ultrasound scan, now we are going to find this fluid-like small cyst like it. Now that's why it's called polycystic, fluid-filled vesicles syndrome. So basically that's what it really comes in. That's where it started, because you do a scan, you find there are really this many. So the other symptoms that you really find is, again, let me explain menstruation again. I got to day 14. So when day 14 now ovulation takes place, where this egg has come from, this space here will start producing the progesterone. So then the progesterone will start rising. So progesterone, now remember we said progesterone is like a pregnancy state period. So this progesterone helps with the thickening of the lining and maintaining the pregnancy. Now, on day 21, if pregnancy has taken place, there are going to be other hormones that are going to be produced, stating, hey, body lean, we are pregnant. Every soldier stay steady.
Yes.
There's a new life that is coming
through.
You got no idea yourself, but there's so much that is really happening in this mysterious body without your permission. So then everything will happen. And then the pregnancy will be maintained, then this will continue. That's why we say, if you come to me today and you tell me, Dr. Njagi, I have been having menses, but I've missed my period. The first thing I'll say, please do a pregnancy test. You could be pregnant. All right, cool. So now, I was just making reference to this progesterone Now, in the event that pregnancy does not happen, this egg will die, and then there'll be, oh, false alarm, it did not happen. Yeah, there was no successful swimmer for whatever reason. And then there's going to be withdrawal of progesterone, and then with the withdrawal of progesterone, then the period, then the thickening of the lining will now shed off. It's an interesting story, huh? So now, what happens now for this patient? Because you don't have really good regulation of this progesterone, you find when now they're gone for 3 months without periods, and then they come, they are going to bleed for an extended period of time. This is basically another symptoms of polycystic ovarian disease. Of course, excuse me, if they are not ovulating, then they're not going to get pregnant. So also infertility or delayed in conception might be one of the things that this patient might actually present with. Other things that we find is because some of the patients are going to, who have polycystic ovarian disease, there could be a little bit weight. There are certain hormones which are going to be changed and produced in the fat layer. Then you might also find out they have more of male hormone, testosterone hormone, which now brings all this dysregulation of the hormones. So sometimes you might find women will start now developing male characteristics, which are going to be, they could be a little bit hairy. You might get some beard. Sometimes you might actually look them in the face, they have this kind of male appearance. Because, also hormones in a way dictate how we end up being. So that's basically what we find with polycystic ovarian disease. We say it's a metabolic disorder. So we might find some patient also having issues with their sugar level control. So they could be diabetic or what we call pre-diabetic. So they are likely to develop diabetes. So again, we also need to really watch that. Again, they are at a risk, because if they have weight, then again the risk of diabetes also we say higher. How do we manage these patients? We manage them based on their presentation. If they are bleeding, then we could put them on contraceptives. Well, let me start. The first thing we tell them is they need to do lifestyle modifications. Lifestyle modification, please do exercise, aim to lose weight, possibly 15% of your body weight, things like that. Do exercise, watch your diet, so on and so forth. So lifestyle modification is number one. Then if the menses are not, we want them to be regular, we can start them on combined oral contraceptives, which is really now going to help them have this regular cycle. If their issues is getting pregnant, we might also give some other medications which are going to help with them being able to ovulate. And then they ovulate, then they can get pregnant.
They are good.
But for patients who are trying to get pregnant and they have polycystic ovarian disease, we also have to be sure that they don't have other factors that would be contributing to infertility, like tubal blockage and fibroids, what we were discussing a little bit earlier, endometriosis, and so on and so forth, and male factor. So sometimes even as a male will be there and say, oh, you're the problem, and kumbe swimmers in a blank bullet.
Shooting blank. Wait. Would you recommend, if I'm coming for a fibroid checkup, would you recommend I also get checked for endometriosis, PCOS? Would you recommend a full checkup? And also, one of the things that I'm loving is how people are advocating for regular doctor checkups. Visit your gyna regularly, go have these checkups regularly. So how would you go about that?
I thank God that He created us in a very mysterious way, that our body gives us signal when things are not right.
Yes.
So when we have symptoms or something that is not normal, something is outside to what we know as normal, please don't usipuze. Just have it checked out. What we really recommend for regular checkup are going to be situations that can be catastrophic. For example, we say have screening of the cancer of the cervix.
Yes.
Because now that, if it's missed out, it can be catastrophic. Have screening of cancer of the breast, or breast examination. Again, if we miss that, we can, it's catastrophic. We say have your blood pressure checked, because we might catch you when you're pre-hypertensive and, help you, diabetes and so on and so forth. So these are the check that should be done. Would I say that you need to have regular check for your fibroids? No, unless there's a problem. Again, remember, we only manage these conditions when you have symptoms. So for fibroid, we say we only treat symptomatic fibroid. So if they are not symptomatic, I find you have a fibroid, so what?
Leave
it. If you have fibroids, and again we say this is what our recommendation says. I'm going in there to, let's say, remove an appendix. I find a small endometriosis.
Yes.
It was really not bothering you. No symptoms. Just leave it, because we have to weigh the benefit and the risk. The moment I take you to my operating theater, there are risks. There are risks.
There are risks.
So we have to actually prove that the benefit outweighs
the risk.
Of course, complication will happen in any treatment and all that. So that's really the balance that sometimes we really miss it out. So you find some of us doctors, physicians, whatever, we are doing too much than we should be doing. So, and that's why we usually say the greatest surgeon is the one who knows when not to operate. So you really have to find all the reason to not operate. So by the time you're operating, you're actually convinced that there's no any other option. And without operation, I mean, the quality of life will not have desires, if it's conception and so on. So check is important, but then we need to emphasize on what should be, regular check, and what should be, don't worry about it.
Don't worry about it.
So if your body, just today for whatever reason you're getting this pain, that is your body just talking to you that there's an injury. Once you have pain, it is your body telling you there's an injury at this point. You have two options: ignore or listen.
Yeah. I don't wanna let you go before I ask maybe one final question. Is that okay?
That's totally fine.
All right. I know I've kept you here for a minute, but
you.
Maybe we can briefly touch on discharge. I saw that question on maybe a previous episode that we did. We know the normal discharge is white creamish for a woman, right?
It's not white creamish.
Ni color? What's the
should be colorless.
Color blind.
Colorless there.
White,
the reason
creamy.
I'm saying creamish, white, and I'm sorry for
no, go on.
Yeah,
no, go on.
It's because that
I stand guided.
That is can actually mean it's a fungal infection. So how does fungal infection come? Does not have smell. It look whitish or creamish. Hiyo ni candidiasis.
What?
Candidiasis.
Candida.
It's a fungal infection.
Oh, okay. So kuna hiyo, and then the normal one should be
usually,
like water.
It should be like colorless. To a little bit of a tinge of like a white.
Si unaona.
Lakini zimesema hiyo, umesemaje?
Kuna hiyo whitish
na
creamy. So nilikuwa namaanisha white.
Oh, you white.
So creamish is so kuna hiyo, kuna hiyo ya white na creamish. Then kuna black. Na kuna dark brown. Na kuna red. Able to walk us through those discharges if you are not in your periods. What could that mean?
I
hope I've asked the right question.
Absolutely,
okay.
absolutely. Right. So all these discharges actually mean something. So there could be a discharge that you're going to get during the time of ovulation. You'll find that your during the time of ovulation, there's more discharge, and the reason is your body is ready for sexual intercourse during your ovulation.
We know, and we are wearing colors, and we are smiling a lot, and we look nice, and we want to smell nice. Hiyo ndio mkituita coffee tunakuja haraka sana.
So there's that discharge, which is really normal discharge. So we usually say the discharge which is not smelly, does not have any symptoms like irritations, itchiness, and so on and so forth. But any discharge now that becomes colored, let's say it's black. Black can mean it's completely old blood with brownish. Red, basically that's blood. And you can have a mucus which is stained with blood. We really need to find where this bleeding is coming from, if it's remote from your menstrual period. Is it old blood? Is it, what kind is it? If it's a smelly discharge, which now can be take whatever color, it can be brown, it can be, that can be now mean it could be a bacterial infection. And what we now find is every discharge that really comes in gets now treated differently. This is a problem. You'll have a discharge, you're going to go in and they are going to test for your urine, they'll tell you have a UTI. So those are very different systems altogether. So when you're having discharge, what is the best practice? Go in, we are going to take a sample of that discharge, we're going to do something we call culture and sensitivity. Culture just means we are letting the whatever microorganism to grow. Once it does grow, we are now going to look at the microscope and be able to tell what kind of a microorganism this is. After we do that, the next thing we are going to do is what we call sensitivity. Sensitivity, we are going to subject it to different medication. If it's a bacteria, different antibiotic. And we are now going to tell you that this bacteria is sensitive to this and this and this and this medication. Unfortunately, what we find with our patient, anytime they have a discharge or some pain, they go to the counter and say, give me some antibiotics. You get some antibiotics?
Yeah. You're good to go.
You're good to go. So that gets better, then comes back. Then antibiotics. Then what happens? You become resistant. Now, we're talking about the discharge. You take some antibiotics, then what happens? Then you start, that clears, then you get this whitish, creamish discharge. Why does it come? It's because of long-term use of antibiotics. Why is it that? The reason is because the vagina, it's usually acidic. It's acidic because of a normal bacteria that lives in the vagina. It actually makes the vagina acidic. So when now you give antibiotics, you actually kill the normal flora or the normal bacteria. It becomes less acidic. So it becomes more, remember when we were talking about nutrient and then, So when it does, remember the vagina is moist and fungi love a place that is moist. So what you're going to end up getting? Fungal infection. So one of the things that we find with candidiasis or fungal infection is on patients who have actually been on antibiotics.
Got you.
Yes.
How is a dry vagina a sign of something is wrong with you?
Yeah, exactly. Yeah, because actually it should actually be moist. And we have to look at the medication you are on. Have you had procedures, and do you have an infections and things like that? Because actually, because this is what you actually get. Patient will come and say, I'm having dry vagina. That does not really necessarily mean there's an infection. It could be many things that are really going on. Remember, the sexual, during that period, you get really excited. There's nerves which are stimulating some glands, because the vagina is made of glands, and the cervix, and now becomes mucus to really facilitate the sexual intercourse. So you could find challenges just somewhere. Sometimes you find that it's just mental block. Mimi siski, so I mean, how?
But anyways, I think we've had a pretty enlightening conversation. I think for the first time, even me as an individual, I'm able to understand the difference between the three. And I'm also able to acknowledge that this is not a joke.
No, it is not.
Yeah, I feel like we could even potentially dedicate this platform to a couple of more lessons, because I think that's the only way we can be able to create awareness, by using what we have. And I believe what we have is a platform. So I take it as a challenge to bring more and more episodes around this particular conversations, so that we can be able to create awareness together. So anytime you feel like, hey, I want to create awareness, and can I go at LNN and speak to our people over there, this is an invitation. Wow. Consider this an open invitation. Thank you. You can come and we can have these conversations together. But I hope you've loved it.
No, amazing. Goodness. You don't know how much I loved your show, and how much my wife loved your show. And, my office, one day we're going to make it to Lynn Ngugi.
Like, guys, I'm just here. I'm right here. I'm right here. I don't know why people think I'm not accessible. I am very accessible. But you see the timing and how effortless this was. I'm a huge believer. There are no coincidences. And when it's God's time, when it's God's time, it will happen. However, I know there are a lot of people who are watching and they would love to connect with you. How can they do that? How can people reach you or your office?
Goodness, so for me, basically on social media. So look for Dr. Njagi.
Yes.
Yeah. TikTok.
Yes. Sana.
So for my office, I'm both in Nairobi and in Mashinani. So in Mashinani, I'm in Kerugoya, in Kirinyaga County. I sit in a facility called Maple Grove Gynecological Center, where we are starting the African Center for Endometriosis. When this goes through, we're going to call you up.
That I'm happy for. Then we can get the statistics.
Most definitely. And then also, I sit in Parklands. There's a building called Park Medical Center. It's right across the street from Aga Khan. And I'm on that floor, 301.
Okay.
Yeah.
Is there a number? Is
there an office number,
line?
Yes. The office line is 0799 500 555. That's our Kerugoya clinic. And actually, that's enough. If you call and you want to make a booking for our Nairobi clinic, they should be able, just call that number and just decide if you want to
come to Parklands or Kerugoya. Beautiful. Do you have a parting shot for our audience? Feel free. And also, if there's anything we've left that you felt, Lynn, I really can't leave here without addressing. Here's your moment.
Well, I think first is to really thank you for giving me an opportunity to really speak about this condition that I feel they are very dear to us, and finding a platform to get an opportunity to talk and to educate. And I really love how you put it, learn, and relearn.
Yes.
Every day is learning, and I feel that the Bible says, to whom much is given, much is expected. And sometimes I'm only one, and I can just go sit in my clinic and see a finite number. I see about 20 in a day. But all I tell my patient in my clinic, the best thing that I can do is really not that piece of paper that I'm going to write a prescription, because anyone else can actually give you the same prescription. I don't have a magic trick. It's to really give you education, because by educating you and you understanding your condition, it really empowers you, and you're going to make decisions that are going to be well-informed decisions, which I find is something that is really lacking, that our patients are really not well-educated, and they're not really well-informed. They don't ask the right questions. And sometimes we, the physician, we're like, we are like,
Yeah.
you don't question doctors. So I'm really humbled that we can get a platform, and really to thank you for the work that you're really doing and the impact that you have in the community. Because all you're trying to do is to make a better community for us and for the generation that is going to come. So mine is really, really congratulate you.
Appreciate
And
you,
really
Doc.
thank your team who,
Yes.
really support you. And I also want to thank my team
Yes.
that have worked in this journey. Lynn has been crazy long. We started, with these surgeries, sleeping on the floor. We've been in, from Bandera to Malindi, just trying to do free surgeries, and so it's been a long journey. So I also want to thank the team that really support us. When we sit on the show, they are really, and I really appreciate the way you thank your team, and they are seeing us too, but behind us, they're really great people who will possibly never have their faces on the show, but do tremendous work. If they left, then these lights goes off. So we really also want to thank those people.
Absolutely.
And my parting shot is usually, I think for me, as for patients who suffer from endometriosis, just to tell them that there's hope, and there's some of us who are there who have 100% dedicated their life to endometriosis and reproductive health. And I have no doubt in my mind, when God thought there should be a guy called Njagi, this was my purpose. And we're not going to rest until there are solutions for women suffering from this excruciating condition. So, period pain is not normal.
It's not normal. And we are going to die empty. We are going to use our gifts for the purpose and make sure that we do everything we can to live that purpose and to live a legacy of, I did not die with these talents inside me.
I had one pastor who mentioned, as you mentioned, that are you ready to bounce your last check? That you give everything until when you give your last check, it bounces because you've left your account dry.
Wow, that's a new one for
Bouncing
me.
your last check?
That's, me, I'm ready, man. Me, Doc, any day, anytime, muni quote kwa hii show. Me, hata mtani quote, hiyo siku ikifika, cause itafika. But I'm good. I'm good. I appreciate you.
Thank you.
Thank you for you taking your time. I say I don't take it for granted that the guests we have here dedicate their early mornings. And funny things, we film all this on weekdays, especially in the middle of the weeks. And I know this is when things are crazy even for you. So I don't take it for granted that all of you are able to create 4 hours, because sometimes they don't get to see what's off camera or how long sometimes we have to wait before we record. So I don't take it for granted that you took time off your busy schedule to be able to come and have this conversation with us. Personally, I've unlearned, I'm relearning. Maybe before you go, our producer AJ has that question. Fibroids and age. The younger you are, the less, or the older you are, the more, and also endometriosis.
Well, for fibroids, if I say we really don't have a rate of growth.
Yes.
So they grow over time. And sometimes they get to a point where they don't grow anymore. What we know for sure, fibroids will grow in their reproductive age. And of course, the older you get, the rate of growth usually kind of slows down. By the time you're getting to your postmenopausal, then what is going to happen is that they'll also start now shrinking. They might not completely shrink. So if you want to draw a curve, you might say from when a girl starts their menstrual period, it'll be a small growth. And then when they reach their 20s, thereabout, they keep growing, and then they'll start slowing down a little bit, prior to, and then when you're getting to your menopause, then they'll start kind of shrinking. So it's very difficult to say there's a correlation between the size and the age. Of course, 20s to early 30s, I don't expect to find very big fibroids. But you can imagine if we are catching them, when are we likely to catch them? Is when they become symptomatic. When do they become symptomatic? When they become very large. So Again, it depends on where we are catching them. We are going to catch them at the age of reproductive, where fertility is now a concern, or where now they're big enough, they're bleeding. So you might now say that we are really getting between 35 to 40, that's where we are getting really big fibroids. But they have been actually growing. And only patient presented because they have symptoms. It can be partly correct to say younger patient, there'll be small fibroid, older patient, they are going to be bigger fibroid because they're actually growing. It's not once where just boom, there's a fibroid. So they start from a millimeter and then over time they keep growing.
Okay. All right. So thank you so much, guys. Man, this has been fun. And I hope, as I said, personally, I know I have a lot of take homes. I always say sometimes I'm the huge beneficiary of these shows. I get to learn so much. Like, I get free consultations, guys, and I try as much as I can to share that with you. So thank you so much for watching. We really appreciate you coming through, and we appreciate you tuning in. Muga, how long have we gone? Yeah, this is almost 2 hours of you sitting with us and listening to these conversations. So that's not something I take for granted. As always, I'm interested in knowing what your take home is on the comment section. And I know we've not touched on everything. So if you would want Doc to come back, what are some of the things you would want him to help us tackle? Leave that for me on the comment section. Also, please make sure you share this video with your loved ones, because I know they will benefit from this information. And also, if you would love to get hold of Doc, or if you want to get in touch with his office, all the contact details, including the offices, are on the screen. So make sure that you can be able to get hold of him through those contact details, and also get him on TikTok. He's a huge deal right there. So go learn a lot of things that we've not addressed that he addresses on TikTok. Kindly go check them out, and who knows, you might benefit from that information. Again, I want to say thank you to you, to my team, for always coming and pulling this together, and also our amazing partners. I say production is a huge deal. I would not have done this without our amazing partners of today's conversation, Kings Developers Limited. I talked about them at the beginning of the episode. So if you want to get yourself an apartment, why don't you take a look at what they have going on? And also, if there's anything you can't share on the comment section, our email is right there, info@lnn.digital. Feel free, and I will give you a response from our email address. I think we've done a pretty good job. So how about I see you tomorrow, our usual time, 10 a.m. or 7 p.m. My name is Lynn. Tuonaneni, my people. Bye-bye.